So now coming to the last talk, I think. So coming to the last talk, I think I was attending a leadership program a few days back, and in that they used to say that, you know, there is always this person who clears up all the mess at the end of every party. So I think inviting Dr. Ritesh to finally clear up all the messes that we have created since morning. So Dr. Ritesh is a senior faculty at LV Prasad Eye Institute and carries you know, a lot of big name papers and fame along with him, and it'll be lovely to help us sort out the messes that we create.
Thank you, Gagan, for those kind words, and very good morning to all of you. Whatever my previous speakers, seniors have been talking about, in this particular set, I'll show what all can be done to make things messy. And so as we were talking about, first create a bit of mess. Okay, so as we were talking about diabetic vitrectomy, the horizons have expanded a lot, and we go ahead with surgery in quite a few percentage of cases, but complications are a part of diabetic vitrectomy, especially there is a significant learning curve involved, and 5% of patients, what has literature been saying, will ultimately develop some form of complication that may require surgical interventions. Initial in your practice, these complication rates are high. Slowly, as you go more and more diabetic, do more and more diabetic, comes down. So I would broadly classify complications of diabetic vitrectomy as intraoperative and postoperative. Some of them are quite easily manageable, don't cause much of an issue, such as corneal edema. This happens directly because of longer duration of surgery, frequent IOP fluctuation. If you keep doing during the surgery, you keep going bottle height up, down, those will cause corneal edema to come, and you can debride the epithelium. I'm little wary of doing it. I want my surgeries to happen much faster. Why am I scared of it? Because in diabetics, if the anterior segment perfusions are not great, you may risk persistent epithelial defects also. You develop fold in Descemet's membranes. If you have a pseudophakic eye, you can inject viscoelastic, tighten the anterior chamber. You can take away of those folds. A lot of people, if you develop a lot of stromal edema, they used sterile glycerine also dipped in kind of sponge and put it on the cornea to reduce the swelling of the cornea. You can have lens opacities. You may touch the lens during surgery, especially when you're trying to indent and do bimanual dissections. A prolonged surgery will also cause cataractous changes. Serum glucose fluctuations can also increase the chances of cataractogenesis. As far as possible, we try and finish the surgery if the touch is not too big, and then tackle it at a second stage. But if it is too big, sometimes it has happened that I've shifted to a cataract, completed the cataract, put in an IOL, and then gone ahead. So those things happen quite often in any vitrectomy, more so often in diabetics, it does happen. The important intraoperative complications we tackle often is intraoperative hemorrhages. There are roles of preventing this. We use pre-op anti-VEGF. It kind of dries up the membranes. I generally prefer giving 48 to 72 hours before the surgery and then take up the patient for surgery. One dictum which I give my counselors and my team is, do not give the anti-VEGF till the surgery date is fixed, fitness is done. Because if you give anti-VEGF and then you don't operate, the crunch is really bad sometimes, difficult to manage. Our wide-angle viewing systems have made life easier in these cases. How do we control it on table is through controlled infusion. We have the VGFI from the Constellation, which is vented gas fluid infusion, which raises the bottle pressure. Manually, you can raise the bottle height. Diathermy, the stumps, the bleeders, identifying, and bimanually, Dr. Gagan had shown very nicely how you can identify those bleeders and take care of it. But the most important thing for hemorrhage is finding the right plane. If all the previous speakers have talked about find that vitreoitis right plane. If you are in the right plane, as you can see in this video on the left, the toughest Lucas membrane can go off quite smoothly without having caused much of a problem. As long as you are in the right plane, you are able to dissect, separate that very nicely, and you leave behind a clean retina. Look at what happens on the right when you don't find the right plane. Is manipulating with a manipulator, and then suddenly you're not in the right plane, the bleed starts to happen. You are thinking, no, it's a small bleed, let me keep continuing the dissection. You don't realize when you're doing your vitrectomy, you're continuing with your cutter, you're not maintaining that pressure. And then the bleed starts to increase, more profuse, and in no time you'll have a large area full of blood and your view starts to get compromised. And that's what happens. And then the first mistake when everybody does here is, as soon as this happens, they take their instruments out. Now the moment you come out with your instruments, you have again caused a hypotony, the whole blood gets spread out. So you have to ensure that you don't leave your tight chamber there. You don't want to land up with a situation like that. How do we manage it is again through raising bottle height, identifying it bimanually, and cauterizing each of those bleeders which is causing it, separate the membrane which is pulling on the vessel, and you will be able to tackle it. Something which we are doing now, we are a group of glue users. So we have this glue study which the results will be coming out soon, showing one of the cases from there. So this is a case wherein this is typically we are doing it for disc bleeders which do not get controlled. So this case of diabetic, we have removed the membranes, there's a disc prolif, came out easily, and then we realized then there is a bleeder happening from the disc. Bottle height was raised, you try and press on the disc with your blunt cutter, but it kept on oozing and oozing again. Tried multiple, did fluid exchange, again it is filling up. So such eyes, if I leave it on gas, by tomorrow I may have a dispersed heme. So herein we have started what we are doing is using fibrin glue, a drop of thick followed by a drop of thin glue you put on the disc. Initially glue was actually designed for CNS surgery wherein you were using this as a coagulating agent. So you just leave a drop of it, a coagulum forms on the disc, collect it over the disc and just leave it there. You complete your surgery, laser. This case was left on air. I'll show you the day 1 post-op. That's the glue coagulum on the disc, and that's day 7, the glue is absorbed. And you are able to avoid that messy first day, no view kind of a fundus. So there's another technique which you can try doing if your maneuvers of controlling disc bleeds are not working. I'll finish a post-operative complication here itself, which is linked to the intraoperative complication of bleed, which is post-operative vitreous cavity hemorrhage. Now the rate is about 75% can have some amount of vitreous hemorrhage post-vitrectomy in PDR. Most of them it resolves within 2 weeks in vitrectomized eye. They can be classified as early and late. Early, which happens within the first 4 weeks of surgery, late, which happen after 4 weeks of surgery. And most of the causes of early post-operative vitreous cavity hemorrhage are some amount of residual clots that you have left in the peripheral vitreous, any iatrogenic injury which you fail to identify, or a bleeder which you fail to identify on table. You have left an incompletely removed fibrovascular tissue which is still pulling onto the membrane, or rebleeding from a blood vessel breakdown secondary to the damage during the dissection of these membranes. Late POVH happen because of an ingrowth which most often happens at the sclerotomy sites. How do we manage? Early, as I said, first we give it a time to kind of resolve on its own, 2 weeks of a period of time. Subsequently, if it doesn't happen, how do we prevent it? I'm talking about first, I'll talk about that. So a complete removal is necessary. You do a good laser. At the end of your surgery, before you close the eye, you lower the IOP. I generally take it down to 10, not under air, it's under fluid, take it down to 10, look for any bleeders, identify those, then I do my fluid air exchange. And I don't close on a hypotony in a diabetic. If I have a slightest of a doubt, I'll put a suture. I don't mind doing that, but I'll not close the diabetic eye on a hypotony. That causes much higher incidence of post-operative vitreous cavity hemorrhages. As I said, anti-VEGF is something which really helps in reducing the risk, and the RCTs, which was a meta-analysis which was done, patients in which anti-VEGF pre-treatment was given, there is much less chances of post-operative VHS. Management, 2 weeks, don't do anything. If it doesn't resolve, you can go ahead with vitreous lavage. Vitreous lavage is basically allow the blood to wash off, go inside, identify your bleeders, try and see if there is any anterior laser missing. You can go that, indent well, clear your peripheral vitreous cut if some blood is left there. Intravitreal bevacizumab study has been done in post-operative also to take care of this post-operative vitreous cavity hemorrhage. That's a video showing a lavage. So that's just fluid coming in and the cutter aspirating. Eventually you reach that big clot which is sitting on the retina, you go and aspirate that, and your view improves, and then you go in and see which areas your laser is missing, and then you can add more lasers. So do a fluid air exchange, clear off all the blood which is sitting on the retina, and then complete your laser. Coming to late post-operative vitreous cavity hemorrhage, herein identifying the cause is very important. It's very important to do a good UBM of the sclerotomy site. You will be able to pick up these fibrovascular ingrowths into the sclerotomy site. Then you can go and target them. Generally, if I have late vitreous cavity hemorrhages, or even now recurrent vitreous lavages, if I need to do, I add anterior cryo to make sure that the anterior retina is well treated, especially around the sclerotomy sites. Switching back again to an intraoperative complication, which is an intraoperative break. No one wants it, but still we get it sometimes when you're operating. And it has been shown that intraoperative tears can happen in about, the study which was done this is way back in 1983, the incidence were pretty high. And very often these tears are closer to, in the anterior tears are more closer to the sclerotomy site, while posterior tears are more closer to around the arcade area. That's what the study said. The incidence have come down with improved instrumentation, but still pretty good. What 10% of cases can have these one or more tears. Posterior retinal break usually caused by traction as you're dissecting this fibrovascular proliferation. And I'll show you this video, which not a great one to see, but big learning about what we were talking about, how to keep the mouth of the cutter away from. So there's a diabetic vitrectomy being done, and there was this patient had a macular hole with some amount of traction around it. Yeah, so that's the hole. And as this cutter is, where membrane is being trimmed, you see how the hole has got enlarged. It was just a moment wherein the hole suddenly became double because the mouth of the cutter was not pointing in the right direction. Then as you're doing this bimanual dissection, instead of doing a blunt dissection, you use your cutter. If your plane is not right, you start using your cutter. You will see as soon as you remove the membrane, there's another hole sitting underneath it. See there. So you have to be careful how your direction of your cutter is. Use these cutters. Now we have 25, 27 gauge cutters. Use them as a good blunt dissecting instrument. They have these beveled edges. You don't need to be on a cut or an aspiration mode so quickly. Create your plane nicely, and then you can start segmenting these membranes. Going forward, the break happens. The incidence of post-operative complication of retinal detachment post-diabetic vitrectomy also comes in. The incidence is much higher. It's reported about 5% of cases, and it happens more with prolonged surgical durations, more number of intraoperative breaks. Complex detachment which require bimanual surgery, the incidence of post-operative retinal detachment is also high. One such horrific case that we had to deal with, it's a recurrent detachment post not playing. Sorry. Unfortunately, it is not playing. Can I just, we have time to just pause and see? Yeah. आया नहीं इसका, प्ले नहीं हो रहा वीडियो. Yeah.
So about the disc bleed, I think that is one of the most dreaded complications. So you try whatever, like you increase your bottle height, you stop for some time, still the bleed does not stop. Ritesh has also shown he has used glue over the optic disc, or some people use triamcinolone over the optic disc. What you can do is you can raise your bottle height more than the diastolic pressure at that time. If the bleed is not stopping, the bleed will then stop. Just wait for some time, and then you keep lowering it by 5 millimeters of mercury every time, and you'll see most of the times then you can get a control over the bleed. If if the bleed still does not stop, it's always better to close the case and take the case 1 to 2 weeks later, rather than going ahead with the case at that time.
Yeah.
I don't know. I've never.
I don't think so, but with a membrane, I think it will be an excessive crunch. I think one important thing is that if you have a bleed, I think it's best to just keep clearing it, because the blood sticks more adherent to the retina than anything else.
If you keep on clearing it, it will keep on bleeding.
No, what I mean to say is that don't let a very big mount form and then you kind of tackle it type.
Two more things which I do is, if I have cleared my posterior pole significantly, putting a small bubble of PFCL there, if the rebleed happens, it goes over it. Removing it later becomes a little easy. Number two, a mistake which I felt I used to make a lot often is I used to continue doing vitrectomy and leave tackling bleed for later.
Yeah,
But I don't prefer doing it now. As soon as the bleed starts, if there are dithermizable points, I'll start dithermizing them then and there, the stumps. I don't wait that a clot, I'll do it later. I'll multiple times go in and out with my dithermy, but I don't let those clots happen or bigger bleeds to happen. The video is here, so I'll just show the video. So this is a case of recurrent detachment with PVR post-diabetic vitrectomy. There was inferior PVR, inferior membranes. Yeah, so we stained it with brilliant blue, got to the plane wherein used the brilliant blue to help me identify this membrane, and then you start peeling it from the center to the periphery, and there are large breaks which have happened. They're almost like, as you're doing it, the breaks tend to enlarge, but herein I was more concerned about getting this each and every tissue now out, because it's something important for us. I was okay to have a little larger peripheral retinotomy, almost like a retinectomy there. I relaxed that area, did a retinectomy localized, and kind of made a much larger single break. As Dr. Dhanashri was talking, your membranes are pretty bigger ones, you can do that, and then you end up putting oil, and the patient touchwood did well. So it was inferior, it was away, so I was able to tackle it nicely. So thank you.
Thank you.
Any role of interface vitrectomy, Dr. Sangeet? Do you ever switch to air if you have a lot of bleeds intraoperatively?
Yeah, if your blood disperses in the vitreous cavity and keep on bleeding, what I generally do is I switch the patient to air, and you see the view becomes better when you switch off onto the air. And you limit the blood to one place, stop it there, and then you can evacuate. Yes, yes. Yeah. Two things.
Yeah, please.
Once we do a diabetic vitrectomy and if we inject oil, and the patient looks fine on the table, but next day if you encounter blood, sub-oil blood, what should be the next, whether you should go again immediately or you should wait, or?
A difficult, tough one. So it's a complication which we don't like to see. So initially I will not be, if amount of blood is not too much, I would ask for a positioning, strict prone positioning. Try and see if that blood over the next 1 week moves away from the center. If it is away from the macula and the patient is okay with it, I will wait on and I'll probably tackle it later with oil removal. If it starts to organize on the macula, then I would go in probably for an early evacuation, say within 2 weeks around, I'll go for it.
There was 1 case, I waited for 1 month. I thought blood is getting clear. But after 1 month, the posterior pole looked very bad.
Yeah,
All
so
fractioned and...
So 2 weeks is generally, before it starts to become yellow, I'll go in, and if it doesn't move away from the fovea, you can make out. So as you're following up this patient, you can see the quantum of the blood is coming down, or is it displacing inferiorly. So I'll be very happy if I put this position and see a streak hyphema coming in. I know the blood is getting pushed more anteriorly. I'll be happier that way. But if not, 2 weeks I'll go in and...
Yeah, but I think very large, thick bleeds, I think you will know that this is not going to go.
Yeah.
So in those, I think it's best to kind of go in within 2
Yeah.
weeks.
2 weeks is also done so that at least the bleeders who have caused this bleed are in the meantime shrunk and coagulated. So when you go in again, you don't encounter the same. You can.
You can do it.
That was the same thing I was going to ask. is that subsilicon, these blood clots, what to do. So recently I've started, if your retina is attached, one thing is there, if your retina is detached, don't do that. If your retina is attached, now what I've, if you can wait for 2 weeks, that is fine. And still that large clots are visible because they form very tough membranes which are very difficult to remove later on. So now I've started using TPA before going in again. I just inject TPA 2 to 3 hours before the surgery. It becomes lysed and it's easy to remove at that time. But if your retina is detached, just vary off that the open breaks, the blood which is lysed will go subretinal, and that will cause problems during the surgery. Yeah, same, the intravitreal dose.
Give it a try. I've not done it. But
Yeah, that's
give
a
it
nice
a try.
take home.
Recently only I started doing it.